So without further ado, caring for the patient with breast cancer with Amy Depue, RN, MSN, OCN, and CBCN. And in just a moment, I'm going to ask Amy to tell us a little bit about all those different letters at the end there. Now, our first question, breast cancer can occur in women and rarely in men. True or false? And while we're waiting for that, I'm going to say that Amy Depue has been an oncology nurse for the past 18 plus years. She's been embedded in the breast oncology division at UNC Healthcare since May of 2011 as a nurse navigator. She holds certifications in general oncology as well as breast cancer care by the Oncology Nursing Society. And she resides in Chapel Hill with the youngest of her 5 children and her 3 dogs, Max, Levy, and Arlo. Amy, welcome. It is so good to have you here. We haven't seen each other in a while, so it's really great to see you.
It is.
Let's see that first question. Breast cancer can occur in women and rarely in men. Looks like we're trending heavily on the true. We'll wait a few more seconds. But I think how are they doing?
Good. They're doing really well.
Good.
This may be a little bit base information, but that's okay. We're going to talk about it anyway.
Well, that is okay. So this is caring for the patient with breast cancer. And do you want to maybe take a minute to just talk about your career trajectory? Again, you've got a lot of letters after your name.
I do.
What got you interested in cancer and caring for patients?
So true story. This was a second career for me. I was had my last child. My brother, an older brother, was in Japan. I'm sorry, Beijing, China. Sorry.
Okay.
He's in Japan right now, but Beijing, China, and he wrote me this lovely email that said, you have to follow your heart. No matter what you're doing, follow your heart. And so, unbeknownst to anybody else who knew me, I had always wanted to go to nursing school.
Oh my gosh.
So I went to nursing school. I had a bachelor's degree, so I went the ADN route and just fell in love with nursing.
Mm-hmm.
I mean, I was already there, but I knew that I really wanted to do labor and delivery because I had all that experience with 5 kids. Didn't like that. I spent an hour on the floor before I was backing out and saying,
you knew what you needed to know. Huh?
Yeah, they don't do things the way I do. So I was actually also spending my weekends being a CNA, and I had an afternoon on a Saturday on the oncology floor, and the minute I walked onto that floor, it was like I was home. So I did everything I did after that was oncology. I hate to say this, I've never done any other nursing. So all of those people who talk about ICUs and things, I just bow to them. Yeah. This is good. We need those people, but oncology has always been where my home was, where I felt great. I moved over here after almost a decade and had 2 kids who were not moving forward with their education after their high school, and so I kind of tricked them into attending classes with me. I got a BSN, and then immediately the very next semester started an MSN.
And the difference for BSN versus MSN for anyone who's not familiar with that?
For me, the MSN is an advanced practice nurse without being a nurse practitioner.
Okay.
And so my interest has always been in education.
Okay.
And so that's what I did.
Great. And
it ended up being finished through COVID, which wasn't a big deal because everything I did was online.
Nice.
So it was a good opportunity. One of my sons joined the military, and the other son is now applying for 4-year schools to finish out his education. So in the end, it has worked out. But
great.
It's just been a lovely road.
Great.
I have no regrets.
Oh, that's good to hear. So we're going to let our community college audience know more about this and your particular area of focus with breast cancer. I'll go ahead and turn it over to you. We can go ahead and advance that slide. I'll head out so you can feel free to take your mask off, and I'll get the camera set up for you. And just a reminder, we'll have poll everywhere going, so be sure to share your answers and think about those questions for Amy.
So thank you very much, and thanks for all of you who are attending today. This is a really nice series, as Tim said, and I hope you all get what you need out of this. We're going to be talking very basic stuff about breast cancer, with some information coming your way about how we go about treating the patient with breast cancer. There will be some questions involved that you'll have ample opportunity to pick the right answer. And remember, this is not going to be your final grade. These questions are more for you to be able to kind of pick out what you've learned from what I'm telling you today. So our objectives today, we're going to describe the types and stages and what kind of testing we're going to use for a patient who has been diagnosed with breast cancer. We will discuss treatment options, side effect management, and most importantly to people like me, the emotional need of a patient with breast cancer. We are also going to discuss the importance of collaboration and teamwork and some of those outcomes, what we're looking for. So by definition, cancer are those cells, those rapidly reproducing cells that a patient has in their body, and we label them with specific disease types, depending on what tissue or blood those cells have reproduced so rapidly in. So, very simply, definition of breast cancer is the overproduction of cells that are not normal. They're going to be well differentiated, and they're going to come from the breast tissue itself. The one thing that I want you to remember about this and about the little slide that we have here is that there are different types of cells in the breast, so we can have different types of breast cancer. We always want to talk about, in the beginning, the numbers. How many of these people in the United States, or even in the North Carolina itself, are afflicted with breast cancer. And if you'll notice on this slide was in 2016. The really sad part about this is that those numbers haven't changed much. I will say that I was doing some research on some numbers that have just recently come out, and I want you to, when you have a minute, go to the American Cancer Society webpage and just look up the current 2022 numbers. And what you're going to see is that we have made some headway. We have a lot more therapies available for breast cancer patients, but we still see a large number of those women who are dying from breast cancer. Has not changed much. 29% is still the ballpark. Those were the people who have been diagnosed with breast cancer, and these are the numbers of. This is still about the same number of cancer deaths. We are second to lung, and we still are kind of running second to lung here. This is the web page that I just mentioned. I want you to pay particular attention. If you go to this website, look at table 1, and you'll see the numbers that I'm talking about. There has been some change, but not a lot. So we have a lot of work ahead of us, and we're making great strides, but it's a long road. So types of breast cancer, this is going to be really important to know and to understand, because there are some types of breast cancer that are more prognostically poor diagnoses, and we will talk about some of those. This same little slide that looks at the breast itself pay particular attention to those different areas in the breast, the lobes, ducts, the nipple complex. Each one of those places can have cancer. If you have cells, you're going to have the ability to develop a cancer. Remember that. And understand that one of the maybe not so surprising facts is that breast tissue is not just the breast itself. We can find breast tissue going up towards the clavicle, under the arm, and those areas are also important to keep in mind when we're talking about where these cancers are. So for ductal carcinoma, we're talking specifically about the ducts of the breast. Those areas, as you can see, are already larger in some situations, but the ductal carcinoma, especially in situ, is going to be located there in the ducts, and it's going to be a cancer that grows where it is. It is not going to be an invasive cancer. It can preclude invasive cancers, but when you get a diagnosis of ductal carcinoma in situ, those are cells that have grown irregularly, but they are not going to travel anywhere out. So think of it like a tennis ball, that if it starts out as one size, and if it grows bigger and bigger, it's just going to stay in the shape of a tennis ball. It's not going to go anywhere else, which is exactly what that. Good thing I know what these slides say. The second type of cancer that we really talk most about, and what we're going to learn about today, is invasive ductal carcinoma. We call it IDC. That is the cancer that can be found in other areas of the breast, and they develop tendrils, almost like a spider, with legs that grow and kind of move in and out. It's the cancer that we all hear the most about. It's the type of cancer that can lead to death if not treated appropriately, and so we'll talk more about that as we go. We also have an ability for, as you can see, those lobes in the breast that can also become an invasive lobular cancer. Behaves a little bit differently than an invasive breast cancer, an IDC, as I had said just a few minutes ago. It behaves differently. It can be a little more aggressive, and there are certain ways we have to look at how we're going to treat the patient who has lobular. And again, you can get an LCIS, which is lobular carcinoma in situ. Again, it's not gonna have the tendrils that grow. It's going to be the cancer that stays in one spot, and we can treat it. We'll be treating it a little differently than we would an invasive. And of course, then the invasive is, like we had talked about just a second ago, it's going to have the tendrils that are going to be moving out through the breast tissue itself. So one of the types of cancer that, I just said a few minutes ago that some of those cancers are more aggressive than others. And if you've heard of inflammatory breast cancer, this is what you're looking at. This is a type of cancer that there will not be any sign of any cancer at all, and all of a sudden the breast is really red, really angry looking, and it will involve a large portion of the breast. It'll also have a characteristic of looking like an orange peel, food orange. This is a breast cancer that can sometimes be thought is an infection. And so for a couple of days, we'll try to do some antibiotics, and unfortunately, the redness and the characteristics will get worse. So it's not wrong ever to treat it as an infection, but we can't do weeks and weeks of infection. We need to get moving and get things started for these patients. So while we are talking about this a little bit, signs and symptoms of breast cancer, everybody there, we do screening mammograms, we do diagnostic mammograms, just depending on a patient's history, but there are lots of different things, different symptoms that patients will tell us they noticed before they were ever diagnosed. And some of these can be just upfront a palpable mass, something that the patient has felt herself, and it feels differently. It feels like there is a harder mass or there's a harder area in the breast. We know that there are areas in the breast that feel differently, just normally feel differently, but there's a very distinct feeling to a breast lump that is growing. There could be some swelling that wasn't there before. Maybe the patient didn't notice it, but then noticed it started growing, started getting bigger. The dimpling, like we talked about with the inflammatory breast, can be there and not be inflammatory, but there has been some changes in the cells that are noticeable to the patient. Nipple retraction is that part. It can be normal, but most of the time is not. And what that means is that the mass is situated beneath the nipple complex itself and is pulling back towards the spine, and so that nipple is pulling back, and what used to be a nipple that was not inverted is now showing as an inverted nipple. The redness, the scaliness, the skin itself can feel kind of thicker in an area that what felt just like normal breast tissue. And then, of course, a big red flag is discharge from the nipple itself that is not related to breast milk or lactation. Sometimes that discharge will be clear, sometimes it's a little serous looking, and sometimes it will actually look like pus, but that is a big red flag for somebody to get in and get treated. So we can't not talk about risk factors for breast cancer. We have to. It's a big topic of conversation every day, all day, every day, every day of the year. But so the question is, what do we have to tell our patients? What do we talk to our patients, even if they don't have a diagnosis of cancer? Maybe their parent had cancer, or another family member has had cancer. So we want to make sure that we're doing what we can to prevent the cancer, or at least be aware that somebody's risk is higher. And one of those, there are many models out there, very many models out there, but one of the ones that a lot of people have talked about in the past has been the Gale model. It's recently, you can go to that website there and pull it up. It's different now than it has been. They've reworked it a little bit. But basically what you're doing is putting in your own information. So all of these things, the age, race, gender, all of those things are very important. It would be very important to actually know the age of first menstrual cycle, and whether or not the patient's had a biopsy, or if there has been talk of one, did they actually have a biopsy, and what those results were. Atypia is another way of saying that there are cells that have changed in appearance, but aren't quite cancerous. So we're looking for somebody who's had a biopsy and the pathology has come back as atypia. And always, always, always a first degree relative, a mother, a grandmother, grandfather, father, sister, those people who are closest and who have had a diagnosis of cancer, that needs to be factored in here as well. So just on the supposition that we have filled this out for somebody else, you can see here that what you end up getting, which is also, remember, based on age and based on history, what the percentage of or possibility of a breast cancer being diagnosed in a patient's lifetime, a female's lifetime. This particular person, we don't know the age, but at her age, has, with this information, has a 34% risk of developing a breast cancer in her lifetime. You have to understand that the concept here is lifetime risk, and what used to be an older woman's type of cancer is not necessarily so anymore. So that's why the age is very important. And all this talk about risk, we are looking for ways to reduce the risk. So we have to think about the types of risk and the things that we can change about those risk factors. So we're actually really talking about modifiable, the things you can change versus the things you can't change. And all of this is very important when you're talking to a patient about the things that he or she can do to reduce the risk of having that breast cancer. So, for example, the things that we can change are the way we eat, how we exercise, or do we exercise. Has a woman ever used estrogen-based products for whatever she is thinking she needs the estrogen for? A lot of hormonal or a lot of menopausal or premenopausal women would use a hormone-based therapy because estrogen keeps us young. It's what keeps our skin young. It keeps our brains sharp, keeps our hair thick. All those things that we value in the female form kind of dissipates as we get older. We produce less estrogen. We have less estrogen. So we add that estrogen to make us feel better, and we are increasing our risk for breast cancer. Things like tobacco use and alcohol consumption speak to a lifestyle that can increase the risk of developing breast cancer. So when we're teaching our patients about this risk reduction, these are the things that we like to talk about. You do have control. You do have a say in how you want your life to go. And if you want to reduce the risk of getting a cancer, not just breast cancer, but a lot of different cancers are based on these things that you can change. The non-modifiable things, the older you get, the more likely it is that you could have a breast cancer or a cancer. Gender. You can't change your gender. And what we really know now is that men are susceptible to breast cancer given genetic heritage. Genetics. You cannot change genetics. And you really are talking about two different types of genetics. You're talking about the genetics that are germline, those characteristics that you were born with, that you got from your family tree or your relatives, and then if you have been diagnosed with a cancer, the makeup of that tissue, that tumor. Family history, of course, goes with genetics. It's very important. But also, there are times when a person who may have had Hodgkin's disease when they were younger, in their teen years, and were treated with mantle radiation, are going to be at a higher risk for developing breast cancer. And you can't change that, but you can be aware of it. So the difference there is that you're going to be able to be proactive about reducing your risk and checking to make sure that you have done the best you can to prevent cancer from happening. Oops. There we go. So this is one of the questions, and throughout this little hour-long talk that we have today, you'll see questions like this. These are questions that are, like I said before, are going to pull you in with some of the stuff that I've given you, given information that I've given you, just to help you remember along the way. I would like to say there's no right or wrong answer, but there's a right or wrong answer. So we just talked about risk reduction and talked about some of the things that are important for reducing risk. So if you will go to your poll everywhere that Tim gave you, see, there you go, some numbers coming in. Which of these 4 answers is associated with an increased risk? We talked about modifiable versus non-modifiable. And so each one of these answers is going to maybe speak to that question by something that I said.
And just a reminder that anyone anywhere can do this. You can even be on the space station or in Antarctica, and as long as you've got a signal on the internet,
You'll get it there.
Yeah. Just go to pollev.com UNCLCN, and you'll see that pop up, and you can go ahead and put in the answer, all anonymous. All right, Amy, how are they doing?
Well, 33% of you got the answer correct. We talked about lifestyle with cigarette smoking. Yes, that is true. And we didn't talk about exposure to chemicals used in hair dye. That is a myth that hair dye actually can cause cancer. And I do not think that we have actually identified that. We do know that estheticians these days will not put dye on hair that has regrown from a cancer therapy, but mostly because that hair won't accept the dye very easily. So it's more a waiting for 6 months to make sure that the hair is actually grown in well. And there's always that myth about living near a high energy above ground telephone wires and the electrical stations that are out there. And that is not exactly true either. It is a myth. But the answer to this question is actually the radiation to the chest. It was the last thing I said about women who had Hodgkin's lymphoma before they were adults and got radiation, mantle radiation, and that exposure has put them at a higher risk. So good job, guys. You get.
And Amy, I wonder if some of our audience members aren't thinking about with hair products and uterine cancer, because there has been a lot in the news just in the last few days about that.
And that is true. There has been some more stuff come up, but mostly what I'm hearing my patients say is, I can't get my hair dyed anymore because I've had cancer. And it's possible that they're exposed to, that the exposure could lead to cancer, but it's probably not going to be breast. But it certainly could be exposure on the skin, which would be a skin cancer. So yeah, this is true. We're going to move on. So we've talked about all this stuff and the risk factors and the things that people need to understand about reducing risk. But the big question is, and it has been a question for many years, is when do we start having our women, female patients, start getting mammograms? There are several agencies who make these decisions, and I have gone with the American Cancer Society just because that's where most people tend to go. Follow those guidelines. The guidelines are all pretty clear. Everybody kind of agrees that around the age of 45, women should start getting mammograms done. And if they have a family history, particularly a first-degree relative, that we may start doing that sooner, about the age of 40, unless there are symptoms that say otherwise. And remember, those symptoms could be a list of different things. This really hasn't changed a whole lot over the last couple of years, although the talk is now starting again about possibly earlier mammograms. Again, I would encourage you to go to the American Cancer Society and look it up. You can also go to the ASCO guidelines, who are very, very clear, the NCCN guidelines. And all of those are available for people just to review. So, and this, I had forgotten, I actually did find this. This, if you remember we'll go back and look. This slide indicates that we're going to start at an annual screening at the age of 45. And so the newest guidelines are here. And they, just as I said, they have dropped that down to age 40 if you have symptoms, if you've got a first-degree relative, if you have a history of biopsy, several biopsies, which of course have only been found because of mammograms, then yes, you should probably start a little sooner. Age 45, you should begin having annual mammograms, and probably screening until found otherwise. We're going to go over some of the indications for the BI-RADS findings, which can change a screening mammogram from a diagnostic mammogram. And just know that the diagnostic mammogram is something that is done after there has been a diagnosis. So if you'll see age 55 plus, I mean, it's if somebody hasn't been given a diagnosis of breast cancer, then around the age of 55, you could choose to do an every 2-year screening. And for those patients 55 and older, when it says as long as you're in good health, that lets you know that the patient has a right, even if they're 90 years old, they feel good, they've got good quality of life, and they want to reduce the risk, or they want to keep an eye on their risk, they can continue to have mammograms. That's a discussion that the patient has to have with her with no diagnosis, with primary care or a gynecologist. But as long as you're in good health and you still have your breasts, you should continue. So to further talk about this, just to kind of give you a little bit better idea, we do have 2 options. We got a screening option and we have a diagnostic option. And the screening is going to be what everybody who has never had a diagnosis of breast cancer is going to get. Everybody kind of cringes when they see this picture because mammograms are painful, but it's necessary. The breast tissue in the female breast can be very, very dense, especially as you get older. And some of it, as you get older, it just becomes more difficult to see any hidden possible mass. When we see a mass on mammograms, it's usually going to be given in millimeter size or centimeter size. So we're talking small, but you also have to remember on all of these options, the layout of the breast itself. You can have a patient with a very small size A cup breast and have a 3 centimeter lesion that's gonna kind of dictate how that patient is gonna do her treatments, starting with surgery. We're gonna get into that. So here's the BI-RADS, and the reason why I want people to really know this about BI-RADS, this BI-RADS information, is if you have an opportunity, you've got a patient that you're taking care of, and They're asking questions about what did they see on the mammogram, or what was the indication. You can always look back on the pathology, or no, I'm sorry, not the pathology, the mammogram report, and it will say BI-RADS and then a number. And so these are what those numbers mean. 0 is usually given with a DCIS patient. And then you get these little kind of clues that the next mammogram, the next mammographer is going to look for is going to be what was in her past. What was her BI-RADS last year? And were we thinking that there was something, if it was a 4 and we did a biopsy, what was the result? But it's a key. It's a clue to what some of this patient's history is. Obviously, if there has been a biopsy done, we're going to follow that through. But if you see in the patient's chart that there has been a BI-RADS 6, that's a really big indication that the patient is in the middle of treatment, and we're actually just checking to make sure, maybe there have been some other things that indicate that the therapy isn't going very well or is going well enough. We can help direct the surgery that may be coming up. And we'll talk about that. We have a couple of different screening options for those women who have had genetic testing and are found to have a BRCA1 or BRCA2 mutation. We do like to do MRIs on those patients so that we're making sure that we're getting everything. A BRCA1 or 2 indication kind of totally changes the treatment vista for these patients. There will be other options for them that aren't necessary for discussion with some other patients, not BRCA1 or 2. If there is a family history, or the patient has very dense breasts, and we feel that there is something that we can't fully recognize on a mammogram, we're going to ask for an MRI. Any person who has done genetics and has a family history of Leigh-Fraumeni or Cowden syndrome, those are both genetic mutations that kind of fall on a familial line, and they are high-risk indicators for not just breast cancer, but several other cancers. So if we know that there's a patient, for example, with a Leigh-Fraumeni mutation, we're going to do a more extensive surveillance on that patient. So the other thing that we have with for a screening and post-diagnosis option for these patients is a clinical breast exam. We used to hear a lot, this is more than a decade ago, we used to encourage women to do about the same time of every month, usually after their period has been, they've had their period, they should be giving themselves they should be giving themselves breast exams. They should stand in the shower and raise their arm and do the pattern that they're taught. But what we know now is that we really, while that's good, we really need to have a clinical exam. It's really important to know if we can feel the mass that is present, or if we don't feel the mass, do we need to do another type of screening? But it's very, very important to have a clinical breast exam done on a suspicious screening, or even after the patient has been diagnosed with breast cancer and has gone through therapy and she retains any of that breast tissue. We need for fingers and hands to feel. So as part of the workup for somebody with a suspicious mass or a diagnosis of breast cancer, we want to do, I labeled this, or I said earlier that it was a somatic testing, germline testing, and that genetic test is done on the patients. They go through the whole process, and it's based on the family tree and the family history. We have talked about this. We talked about this earlier about risk reduction. Anybody with a first degree relative is going to have a little bit more risk, and so we need to make sure that we're not missing anything. A person who has a male relative with a diagnosis of breast cancer is automatically going to get a genetic test done as she's waiting to start her treatment. And certain people of an Ashkenazi Jewish heritage, which is European, and a small area in Europe, but there is a large number of traits in the Ashkenazi Jewish line that lean towards breast cancer. So if we know that there is that heritage, that person is also going to get genetic testing done. So here's your second question, and I hope I gave you enough information to answer this. Which of the following statements regarding genetic predispositions is not correct? So as you look through these, which do you think is not the correct answer? Talked about the BRCA1 and 2 and how that can change the patient's treatment. Talked about Eastern European, Ashkenazi, Jewish heritage. I didn't give you any percentages, but we talked about, again, how that BRCA1 and 2 can change the playing ground.
All right, maybe take just a few more seconds. And we really thank everyone for participating. Amy, how are they doing?
They're doing extremely well,
Great.
because the answer is D. We didn't talk about that, and but that is the answer. Good job, guys. Good job. I think you know a lot more than I am giving credit for. So when we know there needs to be a biopsy, I just want you all to be aware of some of the ways that this can happen. We do core needles quite frequently, and those are usually done under some kind of imaging, like ultrasound imaging, so we can see the area, get the core needle in there, pull out the tissue that we need, the cells that we need, and that goes to pathology. As you can see in the area, within the area underneath the core needle, that's just one of the places it can go. We have to be able to see the area, and so at times there will also be a little clip that's placed inside the breast tissue to indicate where that tissue came from. Stereotactic biopsies, this is a real thing. This is not a made up story. Stereotactic biopsies are usually done when the mass is seen, but it's going to be hard to get to. And so they have to elevate the patient on this table that has her breast in a hole hanging below the table, and then you can see the area that they're biopsying right there, and you can see the nipple on that breast. That would be kind of hard to do. That tissue, if you this tissue is malleable. If you lay down on a flat table on your back, then the breast tissue can go back towards the clavicle. So it changes with your position. So it would make sense that if you have a mass right behind the nipple area, you want to be able to get that clear. You want to have a clear shot at it. And this is the best way that we know to do that. And then, of course, you can always, if it's in a very, very awkward area, very hard to get to, or you think there are some other issues with the tissue itself, we can take these patients to an operating room and do an open incision. Doesn't take very long. It takes longer to get everything prepared, but it's sometimes the only option we have. And I said that we can use ultrasounds. We also can use MRI guided. These are for those really dense breasts that we can't clearly see the depth or breadth of the mass. So we're going to use an MRI. Or tomosynthesis, which is a 3D mammogram. Brings things that you can see. This is the same breast under mammogram versus the 3D, and you can very clearly see that yellow circle is a breast mass. And if you look and try to see it in the same light with a regular mammogram, it just isn't as clear. And always we want to really try hard to get the area that we want biopsied. This slide actually just is addressing the fact that I want y'all to keep in the back of your head that breast tissue, invasive cancers, can get into the lymph nodes, and the very first place that they're going to try to go is up in the axillary. So we will do axillary node biopsies. If we see a mass, sometimes if we can only feel the mass, then we need to biopsy it, because that is a part of the decision making for treatment for this patient. So we've done all this stuff. We've gotten this patient in who had maybe she felt her own mass. She got her mammogram done. They saw something. They've done the biopsy. And so now we've got the patient ready to start talking about her treatment based on her pathology. This is the surgical pathology. It will give us some very important information about what type of breast cancer this patient has. It will take into effect the size of the tumor, and it will also look at the grade of the tumor, and grade is very important. We go 1, 2, or 3. The lower the number, the less proliferative or more slow growing this mass is. We can have a patient who probably has had a mass for years and years, but it didn't get big enough because it didn't grow fast enough, and now it is, but we've run the tests on it and found out it's a grade 1, so that can change her outlook for her treatment. But also we're looking, if we suspect there's something in the axillary tissue, the pathology report is going to give us that information too. So two things that the thing I want you to keep in mind, we have pathology and its staging, which is going to incorporate those things that we just looked at. It's truly the TNM, tumor, node, and metastatic status. And we get that information from the pathology that has been run from the biopsy. There's another staging that we'll talk about in just a second that is staging the patient herself to make sure that, if she had some positive nodes and she has a more proliferative cancer, we might want to check other soft tissues. So we will do some other staging scans to help us determine that. And so the second staging is going to tell us about whether that disease has moved someplace else in the body. And will also determine the type of cancer or type of treatment this patient's going to get. So pathological staging, just like I said, is a TNM system. Used to be pretty short, pretty sweet, based on the size of the tissue and the grading. Excuse me, but back in 2017, we changed the system, and it took more information into effect for downstaging a patient. A patient could have had a 5-centimeter tumor, and in the past that could have been bordering on a stage 3, which was more made treatment more urgent. Treatment is always urgent, but it can tell us a lot about how we should start this patient's treatment. Whether the patient should go to surgery first, or have her chemo first, or Can we omit chemotherapy altogether? And so this new staging system has helped us figure all that out. It will lead us in different directions on how we can best treat the patient. And size does matter. We laugh about this a lot, but this is very, very true. If you remember, I said something about an A-sized cup patient who had a 3 centimeter tumor. Well, so this can give you an idea about the size of a tumor. This first stage 2A breast cancer is, you see like an almond shape as a 2 centimeter versus the Lyme that's a 5 centimeter. And again, you have to look at the breast itself before making any big determination on type of surgery this patient is going to get. So then we have to look at phenotype, and phenotype is the type of tissue, the type of breast tissue that we have in front of us. Phenotype is going to talk more about how that breast tissue grew. Was it sensitive to estrogen? Was it not? We look at 3 identifiers here. One is estrogen, one is progesterone, and the other one is HER2 new. Everybody has HER2 new, but not everybody has a breast cancer that responds to the HER2 receptor. It all goes to say what we're going to be able to give this patient for systemic treatment. It's going to be able to tell us whether we should really, if she is HER2 positive, that's a more dire prognosis. Do we do surgery first? Can we give her systemic treatment to help downgrade the size of the tumor? All of that is based on phenotype and the other staging components, the size, etc. So when you hear that somebody has an ER positive tumor, they are going to be somebody whose estrogen helped grow that tumor. So kind of thinking back towards the very beginning of this discussion, estrogen is very important. But if it's going to be what causes your breast cancer, how do we take care of it? So we know that there are specific drugs that will respond to an estrogen-based tumor. Same thing for progesterone. You can have a breast cancer that is ER positive and PR negative, but she is still an ER positive, so we're going to treat her as an estrogen-based cancer. We are starting to look, there are more markers. That's what these are also referred to as the Ki-67. We have always reported on, but we are now discovering that somebody who has 20% or more of this particular marker has a poorer prognosis. So it makes us consider things a little bit differently. Androgen receptors are going to be susceptible to specific types of systemic therapy. So that's what's on the horizon, and what all of these receptors are what we discover when we look at the tissue of that patient's cancer. So that's why it's really important to make sure your patient understands genetics, and that you understand genetics and how it can make us treat this patient the way she needs to be treated. So triple negative, big topics in medical news these days. Triple negative means that the tissue had no receptors that were responding to their presence, and so we have to use a different type of systemic therapy. Triple negative is also a little more aggressive cancer, so we really have to look at all of that picture to make sure that we're doing the right modality at the right time, the right type of therapy at the right time. And this is just referring back to what I had talked earlier about with the disease state staging. So if we have somebody who has positive lymph nodes, we want to know what else is going on, if there is anything else going on. So we're going to do a CT scan, and a bone scan. And both of those will give us a good and more clear indication that we can proceed in a curative state. So when we're talking about staging, and we've got stage 1, 2, and 3, and then we have stage 4, the first 3 are going to be curative. We're going to try to eradicate this cancer and get this woman back on the road, he or she, back on the road to a very productive and active and good quality of life state. A stage 4, we're going to treat differently because we know that stage 4 is metastatic disease, and so we're going to try to control the metastatic state. We can use a PET scan if we can get insurance to pay for it. We will use a PET scan under certain circumstances, but for the most part, a CT with and without contrast and a bone scan are going to be what we need. If we have any indication that this patient may have some metastatic disease in the central nervous system, then there are certain other tests that we're going to use, MRI mostly, but we can do an LP, lumbar puncture, and test the spinal fluid if we think it's appropriate. So, we just had this very brief discussion, but what would be the most important objective of solid tumor staging? What are we looking for when we stage a tumor? So choose your best answer. We're looking for information, that's for sure. Do we need that staging for risk reduction? Or are we looking at that staging for high risk for disease recurrence, which means the disease coming back after treatment? Are we looking to treat with research protocols? Or are we just trying to provide the necessary information for individual treatment planning? I'll give you just a few more seconds. I think Tim will pop in and tell us when time is up. But so far, so good. I can tell you that. I think the other thing to remember, too, with some of these questions is that as you get closer and closer to taking the NCLEX, you're going to have these types of questions that almost every answer could be right, but you have to choose the one as most right, most correct.
All right, Amy, how are they doing?
Wonderfully well.
Great.
You all are correct. That is the correct answer. Yay. Good job. So we're going to talk about treatment modalities. In breast cancer, we have 3 that we rely on pretty heavily. We have medical oncology. Those are the doctors who are going to take care of systemic treatment. We're going to take care of these patients from moment of diagnosis to survivorship, which incidentally anymore is at the moment of diagnosis. We're going to get them through all their systemic stuff and get them to surgery or send them to radiation or both. And if they become metastatic, then we will treat them in the palliative care setting. Surgical oncology, which is probably could be the least amount of time that a patient spends in this modality, because they're going to be the surgical oncologists are the ones who will work the diagnosis up and perform the surgery. Surgical oncology, pretty simple. Removing the breast cancer tissue, performing the axillary dissections, and on rare occasions, we will do a metastatic patient. If we think that the quality of life will be beneficial by taking them back to surgery, then we can do that. And then there's radiation oncology, and that they're the guys who tend to go last on invasive ductal carcinomas, because they're sealing the deal, so to speak. They are making sure that those edges, the tumor bed edges, are clear post-surgically, and gives that patient another opportunity to reduce risk of recurrence. And so just a thought about the recurrence is patients can get another breast cancer. They can have a breast cancer that has been treated, return, and still be in a curative state. Or the breast cancer can recur and be in another area of the body outside the original breast tissue. But all of those, when we do a biopsy, say on a bone, because we see lesions on the bone from a CT scan or a bone scan, and we have to biopsy to make sure that we're treating the cancer correctly. So if it comes up that it's most related to a breast tissue, then we move accordingly. Radiation oncologists also will do palliative symptom management on a metastatic patient who has bone mets and all of a sudden maybe has excruciating pain. We can take them in and pinpoint the radiation and give them relief. So it's a palliation for symptom management. As I said, the medical oncologists are going to be the primary focus here. We're going to take them through systemic therapy, the chemotherapy or targeted therapy. We're going to follow them on those ER positive patients, are going to have a further medicine to follow after their systemic treatment and after they've been through radiation, if they are going to get radiation, and certainly after a surgery. Those ER positive patients are going to be able to take an oral medication for 5 years, maybe up to 10 years, to help reduce the risk of a recurrence. And in this case, we are talking about a metastatic recurrence. We will, when we say we're going to follow them for 5 years minimum, that's what we're talking about. As long as they are taking an oral agent, those ER patients take an oral agent to reduce that risk, we will follow them. And that includes, even if it's an annual exam, that will include imaging. If they don't have breasts and have not had reconstruction, they are definitely getting a clinical exam. So medical oncology stays around for many, many years. One of the things that helps the medical oncologist are these predictive tests. You'll hear lots of talk, especially, and you've heard it here. We have tissue-based testing that we can use that can determine whether the patient needs chemotherapy. Some of these tests will discuss the percentage of the risk in years 5 to 10. Does the patient need to stay on her anti-hormone therapy? The Foundation Medicine, which is one of several tissue testing platforms that tells us if there are some other mutations that we don't know about. And we may not have any treatments based on those mutations yet, but we're aware that they're there. That is something for later. If there is a recurrence, do we have something at that point in time? It's a very interesting and kind of almost scary to know what we don't know. But we do have the testing available, which we didn't have 10 years ago. Oncotypes have been around for a long time, and that's something that we do use a lot on smaller tumors. But what we're looking for is how well this patient's going to do. If she does take it, is there going to be a benefit for chemotherapy, or is there not? It's all very interesting stuff. So we're getting there. Your patient, that you just met, has got early stage breast cancer. Early stage breast cancer means that it's a curative breast cancer. We found it before it had become metastatic. She's hormone positive. So she's ER, PR positive, or maybe ER, or maybe just PR, but she has positive receptors, and your medical oncologist says that he wants to send out a genomic assay. So we didn't talk a lot about MammaPrint. MammaPrint is one of those predictive tests, but why are we ordering it? So choose your reasoning why. And remember that there are some that are positive and some that are some of these are answers that could actually fit. How are we doing?
We are doing well. Let's take just maybe a few more seconds to go ahead and do that, and then we are. I hate to say this, but we're going to need to wrap up. We're going to need to wrap up.
We will do that. We'll do that right now. So the answer to this question is actually that you got the first one and the second one. Yes, those are correct. The Oncotype and the MammaPrint are not going to identify any herited breast cancer genes, so I feel really badly because I didn't explain it well enough. That's on me. We don't just use them for clinical trials, but that it does help us in deciding the risk for that cancer to come back. It does not actually. We don't actually use it just for that. We do use it to determine whether chemotherapy is indicated. So your answer here is A. That is why we would use that testing. So I'm sorry that we went over, but I hope you got enough information about how to start out caring for a patient with breast cancer. Just know that as a nurse, you're going to be asked to do a lot of things about the emotional viability of that patient. So it's helpful to have all this information. The bottom line is you've got to convey to your patient that we have things that can help cure, and we're going to be there with them from A to Z, beginning to end.
All right. Is that a good wrap up place?
That's a place we can wrap it up.
Okay. And I apologize because I know you've
guys.
got a lot more information there. We're going to have you back because there is so much information here. And let me just
We know this about me, though, that I tend to talk a lot about.
Well, that's because you have a lot to say, and we are very appreciative. Let's
leave this here with Maya Angelou.
Mm-hmm.
This is really why we're doing what we're doing, guys. Very seriously. So thank you for coming in, and we won't have time for questions.
We probably don't have much time for questions. If maybe just a quick one for the students that and I'll let me set this so that I can moderate so that if I do see any others come in, I can go ahead and take those. So if you do want to go ahead and share a question, you can go ahead and do that through Poll Everywhere. And while we're waiting to see if any others come in or any come in, and I know that some of you have to leave now, but what would be your suggestions to a student who is in a healthcare field in a community college and saying, hey, I think oncology might be interesting to me. What are my next steps? How do I figure out if that's really right for me? You mentioned at the beginning you checked out L&D, labor and delivery, and you said that is not right for me. What would help somebody know this is something I should pursue?
So I think if you I think one thing that needs to be considered is just the fact that you want to be able to develop a relationship with a patient. Then the field of oncology is where you can do that very easily, and just know that it's extremely rewarding. The best way to figure this out is to get yourself on an oncology floor. Inpatient oncology. It's different now than when many of us went through because these are the sickest of the sick patients these days. We do a lot of stuff outpatient, but you've got clinical rotations that can help you make these decisions. Find somebody that has been in oncology for a while. Talk to them. Ask them questions. There's no silly question. There's no question that can't be asked 1,000 times. spend some time with a patient, and just know that if you really want to feel like you're giving some good out there, then oncology is a good field to get into. I feel very fortunate that I stumbled into this. It has been the last half of my life has been very, very fulfilling.
And I will say that when I talk to, because I get to talk to a lot of people about their pathways, and one thing that a lot of folks say is, I had a parent, a child, a relative who was impacted by cancer, and that has led a lot of people into oncology.
That is exactly correct. Exactly correct.
Well, I want to thank our audience for being
Yes.
here. This has been great, Amy. We want to thank you. We want to thank the people of North Carolina for their
Yes.
generous funding of the University Cancer Research Fund and the Lineberger Comprehensive Cancer Center. We want to thank our team, Veneranda Obore, John Powell, Oliver Marth, Andrew Dodgson, Nadja Brown, Patrick Muscarella, for all of their contributions to, and they work very hard on each and every one of these lectures.